Right. Hello, class. I'm just recording this lecture to continue and finish up our pediatric abdominal section. So I'm just going to pick up where I left off. So we're going to get into now benign liver lesions. So last lecture we concluded with malignant liver lesions. And we remember that the majority of abdominal masses that we encounter in the pediatric patients, up to 2/3 are actually malignant. So it's more common and more often that you're going to encounter a malignant lesion as opposed to a benign lesion. But to get into some benign lesions that you might encounter in your abdominal studies. So the first one is called an infantile hemangioendothelioma. Right. It's a mouthful. So infantile hemangioendothelioma. God. So this is an infantile hepatic vascular tumor. So this is considered a hepatic vascular tumor. So this is going to be our most common benign liver tumor. So these hemangioendotheliomas, they're broken down into two types. So there's two types. So the first type is a hepatic infantile hemangioma. Type. Type 1, infantile hepatic hemangioma. Type 2. That's going to be a congenital hepatic vascular malformation. Genital hepatic vascular malformation. Type 1. Or type 1. These tumors are the hepatic counterpart to the common cutaneous hemangioma. Counterpart to the common cutaneous hemangioma. Type 2 may represent a vascular malformation. Represent vascular malformation. And regardless of the type, they grow rapidly after birth. With abdominal distension noted. So these are going to be your little infants, you know, where their abdomens start becoming more and more distended. So it's a noticeable distension because these tumors grow very rapidly. And they're often palpated quite easily due to the rapid growth. So a couple things that they can cause. So first thing, obviously, is going to cause hepatomegaly. It could potentially cause congestive heart failure, CHF. May appear as multiple hypoechoic lesions. Hypoechoic lesions. Solitary mass. They may also appear more isochoric. And heterogeneous. and may contain cystic components. So we're talking about a mass that is hypoechoic to isoechoic, heterogeneous, may contain cystic components, so it'll look complex. There are also areas of speckled calcifications seen within the mass. Contains areas of speckled calcifications. So we said these are vascular lesions or vascular tumors. So color and power Doppler. Will demonstrate well within region. This is infantile hemangioendothelioma, the most common benign pediatric liver tumor. So hepatic hemangioma. Well, these may either be infantile or juvenile. The juvenile appearance is similar to that of an adult hemangioma. Juvenile has similar appearance to an adult hemangioma. The hepatic hemangioma is characterized by active endothelial growth. The vessel growth slows down as the tumor matures, but the existing vessels may form lakes within the lesion with little blood flow. Kind of picture this this vascular lesion, it's growing. And as it grows, it's very vascular when it's first starting out. And as it matures, these existing vessels, they start to close up and form what are called, quote, lakes within the lesion with little blood flow. And when we see them in the adult population, they're typically don't demonstrate, a lot of vascularity, but they're very echogenic. And these are those remnant lakes of those vessels that grew when this hemangioma was forming. Risk factors. Risk factors for developing a hemangioma, hepatic hemangioma, include premature birth, and female gender. And they are 3 to 4 times more likely than males to develop hepatic hemangiomas. So 3 to 4 to 1 ratio. As well as having fair skin. Some other benign liver tumors. You have a mesenchymal hamartoma. You also have an adenoma. and focal, nodular, hyperplasia. These three make up roughly half of all benign liver tumors. About benign liver tumors. Mesenchymal hamartoma, adenomas, and focal nodular hyperplasia. So our mesenchymal hamartoma, these are a rare, asymptomatic, benign tumor. That's under 2. The tumor has multi-septate or multiple septations and is a cystic complex mass derived from periportal mesenchyme. It's a multi-septated cystic mass originating from periportal mesenchyme. Periportal mesenchyme. We can also have an adenoma or adenoma. So this tumor is not commonly seen in infant unless liver disease is present, like glycogen storage disease. So not commonly seen unless there liver disease present. With adenomas, serum alpha fetoprotein levels are normal. So blood work with these other liver tumors, you'll typically have elevated serum alpha fetoprotein levels. With adenomas, these lab values are within normal range. Sonographic appearance can range from hyperechoic to hypoechoic, and are non-specific. Sonographically, and here as hyperechoic to hypoechoic. That means it could be hyperechoic, isoechoic, hypoechoic. That finishes up liver tumors and liver masses. So now we're going to transition into some common surgical conditions that you may encounter in the pediatric population. So these are going to be exams that they're going to order for kids that are having abdominal pain, in which the diagnosis could potentially result in a surgical intervention. So the three main pathologies that we're going to cover are going to be appendicitis, intussuception, and pyloric stenosis. So if we remember back to one of our first lectures, the most common cause or non-surgical cause of abdominal pain in a pediatric patient, so non-surgical cause of abdominal pain, was our gastroenteritis. So that's basically like a stomach virus, an intestinal virus, that causes inflammation within the bowel and the intestines. And that'll pass. That's your everyday run-of-the-mill stomach bug that these kids develop. And then the most common surgical reason for pain in the pediatric population is appendicitis. So we will start with appendicitis. Appendicitis. So appendicitis, I guess we could start with a little basic anatomy, just in case, refresher, in case we've forgotten. Okay, so this is going to be our large intestine. The large intestine broken down into several segments. We have our ascending colon, our transverse colon, and our descending colon. So over here is going to be our small intestine. Which connects to the ascending colon in this area over here. So this portion of the ascending colon, or the base on this side, this is called the cecum. The terminal portion of the small intestine is referred to as the terminal ileum. Where the two connect is called the ileocecal junction. So that's going to become important when we get into intussuceptions. So base of the cecum, or base of the large intestine over here is called the cecum. The end of the small intestine where it connects to the large intestine is the terminal ileum. And the appendix is actually an extension of the large intestine. And will come off of the base of the cecum. So what makes appendix studies challenging and difficult is because where this appendix comes off the base of the cecum is different on every patient. So one patient may have it coming off here. Another patient, the appendix may be coming off here. Another patient, appendix may be coming off in this direction. Perhaps it's coming off this way and running up towards the liver lateral. So when you're doing these appendix ultrasounds, it's important for you to thoroughly scan around that base of the cecum come up as high as even the liver. I've found a couple appendixes almost or practically touching the patient's liver. And conversely, I've seen appendixes run very deep. I found an appendix one time on a woman who was pregnant, and we were doing the transvaginal ultrasound, and I actually saw the tip of the appendix on the transvaginal ultrasound. So in addition to having varying locations, appendixes can also be tortuous. You can have an appendix that loops around. So it may make it difficult to follow or track. You know, some may be shorter, fatter, others may be longer and skinnier. So they're all unique in their orientation, their lie. So some other things that make the appendix ultrasound very challenging is that a normal appendix is very small to begin with. So abnormal appendix has a greater than 6 millimeters. So when I tell a parent, you know, when I'm doing an appendix study, trying to find these things, they're difficult to find, I'm not going to lie. It's one of the more challenging ultrasound exams you're going to do. I tell them, you know, like a normal appendix, you know, is less than a half a centimeter in diameter. So just think about that, you know, the little centimeter marks on a ruler. A normal appendix is going to be less than half a centimeter in diameter. So I'm looking for something that's less than a half a centimeter in diameter that I don't know exactly where exactly it's coming off of this cecum, which direction it's going in, if it's tortuous or not, if there's other bowel overlying it. So some of these, if you think about it, if I'm kind of looking at this patient like this, like what if this appendix is actually coming off, like if that's my, you know, cecum and it's coming off posterior behind it, it's actually retrocecal. And this cecum is full of gas, full of air, you know, it creates a pretty big wall of shadow. It's almost nearly impossible to try and visualize that appendix retrocecal. So again, they're not always visualized on ultrasound, you know, and it's good to let the parent know that, you know, before going in, like it's not, sometimes it's not always visualized, you know, we're going to do our best to try and find it. You know, we're trying to avoid, you know, radiation from doing a CAT scan. So we like to start with the ultrasound examination. But yeah, it's difficult. So not only being, you know, the location being different on every patient, it's very small. And another thing also is that we have to apply significant pressure to an area to visualize. This isn't the type of exam where you can just, you know, gently put the probe down. You really have to push quite significantly on the patient. And depending on their pain threshold and how much pain they're in, you know, this can be quite challenging. The kid may start fighting you, crying, kicking and screaming, and you know, depending on the age of them, you know, they might be very nervous and really hard to comply. So that adds another challenge to the exam as well. So when I'm doing an appendix study, I like to have the child, tell me exactly where it hurts. Point with one finger only, not a whole hand, not multiple spots. Give me one finger where it hurts the most. And I've found that if it truly is appendicitis, those kids will point exactly where the appendix is, and will make my life a whole heck of a lot easier. So they'll point one finger, boop, right there, and that's where I'm going to start. I'm going to put my probe there, and hopefully, if I'm lucky enough, I'll be able to see it. For imaging, we're going to use a high-frequency linear probe. Using high frequency probe. So in these cases with appendicitis, our radiologists, they liked us to start with the highest frequency possible and kind of work your way backwards. So start with whatever's available to you. In our lab, it was a linear 14 megahertz probe, which is pretty high frequency or really high frequency. And then we'd slowly, work our way backwards depending on the patient's body habits. So if it was a thicker, chunkier kid, we may have to switch down to a linear 7. We typically didn't use a curved probe unless, it was a extenuating circumstance, but the images that you get with the curved probe aren't as quality as with a linear probe. So we typically stuck with the linear probes. So we'll get into a little bit now some of the pathophysiology behind appendicitis. Just a quick aside, I had an order one time from a doctor asking me to find a left-sided appendicitis because apparently this patient was having left lower quadrant pain, and they were concerned maybe there was appendix on the left side. And I went to the doctor, I'm like, you ever heard of this? And they're like, yeah, no. Appendixes don't grow off the left side. According to radiologists, maybe potentially appendix hung a little bit over midline, but that typically is something that they only would see in the older population as opposed to young pediatrics. So I got that kid up here, for the exam, and I took some pictures on the left side just to show that there was no mass, no fluid, look for, potential area of pain, what could have been there. And then I got to talking to the mother, and she informed me that the patient actually had an appendectomy about 3 years prior. So I don't even know what they were telling him. I guess the radiologist downstairs said potentially he could have had 2 appendixes. So not only was this like so far-fetched, but no, appendix does not grow back, and appendixes are not located on the left side. It's actually pain could be referred to the left side, but a left-sided appendix, status post-appendectomy, yeah, no, that's not going to happen. So appendix. a blind ending tube-like structure, which extends base of cecum. Important is that term blind ending, because it's going to be up to us to prove that that structure that we're imaging truly is the appendix and truly is blind ending. So appears smooth walled. So when you're imaging in the right lower quadrant looking for this appendix, you're going to see other loops of bowel down there. And the small intestine could potentially get mistaken for the appendix, loops of small bowel. But you'll notice the small bowel will have more undulations. You'll be able to really differentiate, the difference in the two bowels. So the small intestine is not going to appear as smooth as smooth as the appendix. So it'll look more striated. More the walls will appear rougher. Another thing, the appendix, another characteristic will not peristalse. So if you find a structure that you believe is the appendix, stay on it for a little bit and see if it peristalses, because the appendix will not peristalse. So if it starts peristalsing and moving on you, you know that's a loop of small bowel. It's not the appendix. So the appendix will not peristalse. So patient symptoms. So patients will have pain, typically right lower quadrant pain, potentially left lower quadrant or right upper quadrant. Again, depending on the location of the appendix or if they're having any transient referred pain. So typically the pain is going to be in the right lower quadrant. Patient could potentially be febrile, have a fever, low-grade fever. Can't spell nausea. Vomiting. nausea. Worse filler. So vomiting and nausea. They'll have elevated white blood cells, an elevated white blood cell count. So that's another factor I like to look at before I get the patient up. I'll look at their labs, see if they have an elevated white blood cell. Another lab, another marker that I always like to look at too is neutrophils or absolute neutrophils. I've found a little correlation between the two. You know, if I get a kid that they want to rule out appendicitis and his white blood cells and neutrophils are both elevated through the roof, I'm like, yeah, this is probably going to be positive. So pain, fever, vomiting, elevated white blood cells, neutrophils. You know, with real true appendicitis, these kids are really going to be in pain. So when you put your probe down and you start pushing, they're going to hurt. They're going to really have to tough it out, you know, for you to get the images that you need. That's, I mean, your heart goes out some and you feel bad. So you try and, you know, do your study as quickly as you can, distract them, again, talking, thinking about other things, you know. So patient symptoms, pain, fever, vomiting, elevated white count and neutrophils. So what causes appendicitis? So appendicitis occurs when the appendical lumen becomes obstructed and subsequently infected. So what does that mean? So if this is our appendix hanging off the base of our cecum, cecum is where the stool is formed. So essentially it's poop. So what goes into the appendix must also come out of the appendix. So I've seen cases where they have a lot of fluid within the cecum. I can actually visualize, you know, fecal material coming into the appendix and kind of coming out of the appendix, kind of swishing back and forth. But again, remember, the appendix does not peristalse, so it does not contract. So even though you see stuff looks like it's coming in and out, you're not going to actually see the contraction of the appendix, the peristalsis of the appendix. So what happens is you can get some material coming in, become lodged, and block that appendical lumen. So that lumen is that inner layer, that inside of the appendix. It becomes blocked, and then the material that's inside here, you know, will start to decay, break down, and eventually infect the wall of the appendix. So you'll wind up with thickening of the wall, thickening of the mucosal layer, dilatation of that appendix. wind up potentially with fluid, free fluid developing around the appendix as a result of the infection. So you can get free fluid development. Free fluid. So the thing we have to worry about now with acute appendicitis is the potential for rupture. So we can have rupture or perforation of the appendix. So in infants, and small children, the progression to perforation / rupture is more rapid than adults and older children. So acute appendicitis is a fairly quick process. You know, that's another thing I forgot to mention too. When you're asking about the patient's pain, how long have they had this pain? So appendicitis symptoms, it's a sudden onset, you know, all of a sudden, you know, like, yeah, I woke up this morning, all of a sudden, just, you know, it just hurts, you know. If the patient tells you, oh, I've had this pain, you know, like, you know, for a week, 2 weeks, you know, multiple days, you know, probably not going to be appendicitis if they've had this pain for like a week now, you know, and it's just, if it comes and goes, you know, ebbs and flows. This is a pain that's, you know, it's an onset of pain and just, it gets worse and worse and worse until you have that perforation or rupture. So in infants and small children, the progression to perforation or rupture is more rapid than in adults and can actually occur within 6 to 12 hours. Per 6 to 12 hours. So, you know, if this appendix ruptures, we now have fecal material, which contains a lot of bacteria in it, entering our peritoneal space. and perforation. Perforation. Narrow tendinitis. Spell that right. Parrot. All right, oh, nice. I'm sorry, folks. Peritonitis can also lead to abscess formation. And eventually sepsis. Again, if we're imaging, remember, there's a differentiation as to where it's coming off the cecum. So I will image, basically in the entire right lower quadrant, from the umbilicus all the way up to the base of the liver and down and into the lower portion of the pelvis area, because it could potentially be diving down towards, towards the bladder. So anywhere, from the bladder, essentially up to the base of the liver and all the way out lateral. I found appendixes very lateral, very medial, up high, low. So it's up to you to really, scan that right lower quadrant quite well. So I know our PowerPoint says to start with a curved array. I disagree. I say start with your highest frequency transducer and work your way backwards, because you're saving yourself time. The radiologist is going to want those high frequency images because you can, without a high frequency transducer, it's hard to really visualize that mucosal layer of the appendix to determine if there is sign of rupture. So with a curved probe, you're not getting that resolution or detail to really examine that mucosal layer for signs of potential rupture. So with appendicitis, sonographic presentation. So what's going to look like on ultrasound? Graphic presentation. So just kind of peeking ahead some of the images. So if we have an appendix coming off the cecum and we feel that it is positive for appendicitis, so what it's going to look like is we're going to have, first off, dilatation of the appendix. So you'll typically see a more echogenic inner lining and a hypoechoic outer layer. Another thing to keep in mind, the majority of appendicitis will begin in the tip. So you may have just early tip appendicitis. So this segment may potentially measure, 7 or 8 millimeters, whereas the more proximal segment could be, 4 or 5 millimeters within your normal range. So you're going to wind up with thickening of your mucosal layers. Again, we mentioned that the appendix will typically have a normal, thin, smooth wall. In appendicitis, those walls become thickened. Sonographic presentation, we have so walls. We have dilatation. Movement. So this inner chamber, the lumen, is going to become dilated. We have dilatation of lumen. So diameter greater than 6 millimeters. Measure transverse. So if we were to take this appendix and do a transverse image, the measure will look something like that. We want to remember to include the hypoechoic outer wall, so it's going to be an outer to outer measurement. Measure transverse, outer to outer. And it should be a nice perfect circle, which is going to make you also help you to differentiate the appendix versus small bowel. So small bowel will typically have more an irregular shape to it. It's not going to be a nice perfect round circle like that. The only caveat to this that I discovered is if the appendix has ruptured, it's going to kind of look like a flat tire. So you'll get something that may look like that now. So I actually got tripped up on this with when I was scanning one patient. I was able to see the appendix in long like that. Nice image. And I was like, oh, this is like, it's inflamed, it's hyperemic, hypervascular. I get a nice picture like that, and I'm trying to get in transverse now my view to get a good measurement. And no matter how I go or angle or turn, I can't get a nice circle. What is going on with this thing? Like, is it the appendix? Like, am I like really like, am I sure now? Because no matter what I do, it was like that. And then the radiologist explained to me the reason you couldn't get it like that is because it was ruptured. It was leaking out the fluid, so it was kind of like a deflated balloon, like kind of floppy now. So it didn't have that internal pressure to maintain that nice circular shape. So if you happen to see an appendix that looks like that, it's probably ruptured. So in addition to dilatation of the lumen, appendix will be hypervascular. Hypervascular or hyperemic. That's another term that they may use to describe hypervascularity. So you put your color Doppler onto this appendix, make sure your scale is low because the velocities are not going to be fast. So you can even potentially use power Doppler. So you put power Doppler or low flow color Doppler, you know, this thing's going to light up with color on it. So you're going to see vascularity, particularly along the appendix. So you may get some flow in the appendix itself, but particularly the walls are going to light up with color. We'll use different colors. A little orange on there. So you'll get hyperemia or hypervascularity, particularly along the walls of the appendix. And depending on how severe the infection is, you know, you may also demonstrate increased vascularity within. So you might be picking up some segments of that wall, but the wall is going to light up for you. So you're going to see hypervascularity along this wall. Another sign of a positive appendix, it's going to be non-compressible. So a normal appendix, we said there's no obstruction. So the fluid or fecal material that's within this appendix lumen, when you compress it, you know, you're able to shift it out or squeeze it out essentially. So you should be able to compress a normal appendix. A patient with positive appendicitis, the appendix becomes non-compressible. We have hypervascularity around the wall of the appendix, a hypervascular wall, hyperemia, non-compressible, dilatation of the lumen, thick mucosal walls. You can see periappendiceal fluid. So response to that infection, we'll have fluid developing around the appendix. Also going to look for any appendicolith. Slash fecalith. So an appendicolith or fecalith, that's essentially like a little poop ball, if you will. that gets lodged in here. And eventually over time, that appendicolith or fecalith will become calcified and create shadowing. Similar to like a gallstone. Or a kidney stone. These can become quite large. So those appendicoliths will create shadowing. So in addition to periappendiceal fluid, you can also see echogenic fat surrounding appendix. The area around the appendix, you'll notice that the fat and tissue typically becomes echogenic surrounding the appendix. Another sign of infection. It's going to look right around that appendix. We can also potentially see enlarged lymph nodes. So it's important to look for some of these other ancillary signs of appendicitis, because remember, we may not potentially be able to visualize the actual appendix. I mean, when the appendix is positive, it's infinitely easier to find it, locate it, diagnose it than it is a normal appendix. So when there's acute appendicitis, it's definitely easier to find. But again, we may not always see it. So we also have to remember to document and look for these other ancillary signs like enlarged lymph nodes, any free fluid. Look for any signs, of echogenic fat that can indicate infectious process. So I think that's about it for appendix. Talk a little bit now about intussuception. Just want to make sure I didn't miss anything. So that's it for appendix. Too bad Morgan is pregnant. She would have been a good candidate for us to practice trying to find appendixes on. But that's another thing. You'll often get an order to rule out appendicitis for pregnant women. Typically, it's not an exam that's ordered for adults. They'll go straight to a CAT scan just because it's much more difficult on an adult. It's much more layers that we have to scan through. Their abdomens are much larger. But on pregnant women, we can't do a CAT scan. So they'll attempt with an ultrasound, and you get a woman and her like 36 weeks pregnant, ready to give birth, and we're trying to look for an appendix, and that baby is pushing everything out of the way. So that makes it quite challenging. But anyway, so with intussuception now. So this is the most common acute abdominal disorder in early childhood. So intussusceptions are actually fairly common. Make sure we're responding this right. Intussusception. So the best way to think about intussusception, it's a telescoping of bowel into each other. So you get two loops of bowel, and one pushes itself into the other and actually causes a telescoping into that first loop of bowel. So got a loop of bowel here, and another loop of bowel here. So this loop of bowel will actually kind of push into this other loop of bowel and force this wall of the bowel to kind of prolapse inward. So you get a looping of this bowel into this bowel. This is kind of what is described as like a telescoping of the bowel. So this bowel pushes and intrudes into this loop of bowel and kind of telescopes into it. So this condition occurs when bowel prolapses into more distal bowel or is propelled in an antegrade fashion. You can also have, say, that same loop of bowel, the more proximal portion or this segment of it kind of like involutes in and starts prolapsing inward. So kind of folds in on itself. It's another way an intussusception can form. So again, you get like this telescoping. So I know a lot of people or a lot of techs, when they get an order for an intussusception, they start getting all nervous and worried and freaking out like, oh my God, I don't know what I'm looking for. I don't know what to do. These exams are very, very easy. Do not be afraid of these exams. An intussusception will look like a giant target sign. So if this patient has a positive intussusception, when we are transverse on that loop of bowel, you're going to see what is called a target site, and they're going to be very large. Do some of the different layers about. So you'll be able to discern, some of these multiple layers about. This is going to look like a big donut like that. It'll stand out right away. It'll catch your eye, I promise you. If this patient has a large intussusception, you will notice it. It's just up to you to be careful, make sure you're scanning through that entire abdomen. So with intussusception, patient's symptoms. So it's going to be obvious abdominal pain. With smaller children, it's going to be inconsolable crying. So I've had these little kids, all of a sudden they have these bouts, just really intense abdominal pain, and they're just hysterical crying, and they're inconsolable from the pain, And from my experience, this pain kind of comes and goes, or comes in waves or episodes. So they'll demonstrate inconsolable crying, abdominal pain. They could potentially have bloody stools. Other inconsolable crying, or colicky. There could potentially be a palpable mass. Scanning. So our scanning technique for intussusception, we're going to use, again, high frequency. Use high frequency linear probe. And the reason we're using a high frequency linear probe is because we want to have good detail and good resolution. And the other reason is the typical age range for an intussusception. So age range. So it can be from about 10 months to about 10 years. So that's going to be at the maximums. Typically, we'll see it in patients that are from 1 to about 6 or 7. But it's typically going to be the young children. So it's going to be your 2, 3, 4-year-olds, 5-year-olds at the max. I wouldn't even go as high as 7. Typical range, I go between 1 and 6. We don't typically see it in older children. I think the oldest I ever had a kid with an intussusception was about 9. Actually, correct that. I found an intussusception on an adult when I was doing a portable, but this woman had some other underlying bowel issues going on. I think she had like all kinds of bowel resections and surgery, so things were kind of a little atypical for her. But so yes, it's typically found in the younger children. So we're talking about from 1 year to about 4 years, 5 years old. These are young children. We're going to use our high frequency transducer. Again, right lower quadrant. So the reason we begin in the right lower quadrant is because that is one of the more common places for an intussusception to develop. So if we go back to our drawing again for our large intestine with our cecum here, we have our terminal ileum. A common site for an intussusception would be a ileocecal intussusception, where the terminal ileum will telescope into the cecum. So you can get a telescoping of that terminal ileum into the base of the cecum there. So we like to begin in the right lower quadrant. Scan and transverse. So I will typically do still images, superior to inferior. Of right lower quadrant. So I'll do a series of still images, superior to inferior in the right lower quadrant, making sure the image ileocecal junction. So I'm going to try and show that ileocecal junction in my images. Then after I do some still images, I'll do a transverse sweep. So I'll do a clip. I'll take a clip of the right lower quadrant going superior to inferior, just to show the radiologists I've checked. And you're going to be scanning along that ascending colon. So I'll do a transverse sweep, sweeping through the right lower quadrant along the bowel. Then I'll scan sagittal. So I'll kind of reverse the process now in sagittal. I'll scan lateral, medial, and right lower quadrant. So again, now I'll do a series of still images going lateral to medial across the right lower quadrant. And then I'll finish that up with a nice cine loop clip, just me sweeping across the right lower quadrant from lateral to medial. So after I finish right lower quadrant, you then proceed to right upper quadrant. So scan right upper quadrant in the same fashion. We're going to scan the right upper quadrant, same fashion. Start in transverse, start superior to inferior, just work your way down. And scan lateral to medial. And then we'll just continue working our way across that child's abdomen. So we scan midline, upper, midline, lower, left, upper, and left, lower quads. So essentially, we're doing all four quadrants, the same thing, transverse, long, still images, sweeps, as well as the midline upper and midline lower quadrants. Essentially, your midline lower is going to be your pelvic region, or just above the bladder. Midline upper, midline lower. So all four quadrants plus the midline. So that way you know you've covered the entire bowel. The reason this is important is because the intussuception can potentially develop anywhere that there's bowel present. So I know our textbook doesn't mention this, not our textbook, but this PowerPoint, but I'm just going to explain to you, there are actually two different kinds of intussuception. We can have a large bowel intussuception and a small bowel intussuception. So, large bowel intussuception. So as the name implies, this involves an intussuception of the large bowel. So of the colon, of the cecum. So large bowel intussusceptions will typically measure over centimeters in transverse. diameter. We get our nice, pretty donut picture. Throw some calipers on there and take a measurement. So a large bowel intussusception will typically measure over 3 centimeters in diameter. And the reason this is important to differentiate between a large bowel and a small bowel intussusception is because large bowel intussusceptions typically require surgical / radiology intervention. The reason I put radiology intervention is because there's a procedure that the interventional pediatric radiologist will do to try and correct this large bowel intussusception. And it involves actually strapping the kid down. It's a terrible, well, not terrible procedure, but well, it is. But the procedure involves, you know, strapping the kid down, and they insert a catheter into the child's rectum, and they start administering puffs of air into the colon, you know, into the rectum. Well, they insert their catheter into the rectum, and they start inserting puffs of air into the colon in order to try and push that loop of bowel back out. So they'll insert little puffs of air and try and push that telescoping loop of bowel back out. If that procedure isn't effective, then they will require surgical intervention to correct that intussusception. Again, the radiologist will try with that other procedure to try and avoid surgery. But if that procedure is unsuccessful, so it's almost like a reverse air enema, if you want to think of it that way. So the reason, again, I said to differentiate between these large bowel and small bowel intussusceptions is because small bowel intussusceptions, which measure less than 3 centimeters, typically less than 3 centimeters, are actually transient. So they will come and go, and thus do not require a surgical intervention. Small bowel so this involves 2 loops of small bowel. Measure less than 3 centimeters. Do not require surgery. These are transient nature. What I mean by transient nature, they will form, stay there for a little while, and then kind of undo themselves. I've actually, witnessed this on ultrasound. So I remember scanning this one kid. I found an intussusception. I called the radiologist. He came in. He happened to be, one of our big pediatric radiologists. So he gets really excited, with these these types of studies. So he's like, all right, stay on it. Let's watch it. Let's watch it. So we stayed on it for a while. And sure enough, the thing slowly, started undoing itself and then relaxed. But when that bowel is suscepted, we'll use that past tense word, that child will experience that periods of inconsolable crying where they're just in tremendous amounts of pain. So that's why these kids have those transient waves of pain, that those ebbs and flows of pain, because it's these small bowel intussusceptions that are forming and then relaxing, and then the kids at ease. So it's actually kind of nerve-wracking, for a parent, your kid all of a sudden just screaming out of control, you can't calm him down, just tremendous amounts of pain. And that lasts, 5, 10, 15, 20 minutes or whatever. And then all of a sudden it's like nothing ever happened. The kid's like completely normal and fine. And all of a sudden, well, bam, again, tremendous amounts of pain. Parents have no clue what's going on. Like, what do we do? So more often than not, those are those small bowel intussusceptions that are transient in nature, that are just forming and then dissipating. And my doctor talked about some of the theories as to why these intussusceptions form. One of his theories is he believes that enlarged lymph nodes act as kind of like a trigger point or focal point that causes these intussusceptions to form. And these enlarged lymph nodes could be caused by, like viral infection or bacterial infection, gastroenteritis, strep, potentially kids that have had like strep infections. That's another thing to remember too. Like strep throat, you'll wind up with enlarged mesenteric lymph nodes or lymphadenopathy within the abdomen, mesenteric lymphadenopathy. So kids with strep throat will often also have some belly pain. So that's one of the questions I'll ask with the pediatric kid coming in, if I'm doing like an intussusception or an appendix study, have they had any recent illnesses? Have they had strep throat recently or anything like that? I found that correlation between belly pain and strep throat, actually. So again, small bowel intussusceptions involve 2 loops of small bowel. They measure less than 3 centimeters in diameter. They do not require surgery or intervention, as these are transient in nature. Again, remember, we're scanning throughout the entire abdomen. So this is going to be your typical transverse view. So the radiologist is going to want to know how large it is, so you'll get your diameter. You'll also put color, Doppler. So you'll put color Doppler on. So the color Doppler, you should see concentric rings of color. Within the bowel. With your color Doppler, you see little rings of color. And that's a good sign too. You also want to see color because that shows that the bowel is still receiving blood supply and still has some vascularity to it, but you should see rings of color. And then you'll also try and attempt to get a longitudinal image of your intussusception. So you'll try and want to visualize just how long of a segment is involved with the intussusception. Look kind of something like that. So you'll get a diameter measurement, and then you'll try and get as best you can a longitudinal measurement. So you'll try and measure how long of a segment is intussuscepted. So that'll also help the radiologist to determine, how difficult this could potentially be to reduce doing that air enema procedure. But from what I've been told from some of the radiologists, that could be a little misleading. They've had very short segments of intussusception that are very, very difficult to reduce, and then surprisingly very long segments that were quite easy to reduce using that air enema procedure. But again, do not be afraid of these intussusception studies. It's actually quite easy, and the hardest thing is just dealing with the crying baby, to be honest, and trying to calm the parents down and keep the child still while you're getting these images. But again, it's just quadrants, boom, 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 sweeps, picture, 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 sweep, picture, 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 sweep. Superior to inferior, lateral to medial, in each quadrant and midsections, and boom, you move on. So some of the literature describes this long axis view as a pseudo kidney or sandwich sign. This is exactly how you guys want to be enjoying your nice holiday weekend, is watching me talk. At least it's rainy now, probably. I'm just going to assume it's raining this weekend. You guys are watching this in the comfort of your home on a nice rainy day. All right, so the last surgical procedure or potential examination that could require surgery in the pediatric population that is common for us sonographers would be ruling out a condition called hypertrophic pyloric stenosis. Red. Why not? Let's switch off and do some red. Hypertrophic. Stenosis. So if we go back and think about our anatomy of the stomach, esophagus coming down, we've got our stomach. Not bad. Not bad for my artwork, I guess. So we know that there is a sphincter or a muscle at the base of the distal antrum of the stomach, where the duodenum connects to the stomach. So this is going to be your first segment of a small bowel. Your duodenum, duodenum. You'll have your pylorus channel. So the pylorus channel is the little space in between that pylorus muscle or that pylorus sphincter. And it helps to control the passage of food and water from the stomach into the intestine. So typically when the stomach is empty, that channel is closed to prevent gastric juices from secreting into the duodenum. And then when we eat or drink something, that the muscle relaxes and opens up, and the channel opens and allows for the passage of food and water, or food and liquid, into the duodenum. So in this condition of hypertrophic pyloric stenosis, we get an abnormal hypertrophy of that pyloric muscle. So there's abnormal. You guys read it? You guys can't really read the red too well. Yeah. Red. There's abnormal hypertrophy. Pyloric muscle. Which restricts and eventually obstructs flow of food and liquid through pyloric channel. Draw this a little bit bigger here. So what's going to happen now is that that pyloric muscle is going to become hypertrophied and thickened. And prevent food from flowing through that channel into the intestine. So this condition can be seen. Typically, we get these babies around 3-4 weeks. So we'll typically see, we'll say, condition occurs 1-5 weeks of age. That's also important to know. So if this order comes in and the kid's a year old, they don't have hypertrophic pyloric stenosis. Now, even if they're like 4 months old, they don't have hypertrophic pyloric stenosis. This is a condition. We typically see this when the kid's about a month. So this muscle starts developing or becomes overdeveloped, becomes thickened. And once they reaches a critical thickness and severely limits flow through that channel, when the baby eats, it's not passing through. So that stomach is going to become very distended. So stomach becomes distended. Which results in projectile vomiting. So it's funny what each doctor's definition of projectile vomiting, because little kids, as you know, and your mothers out there, kids throw up. That's what they do. They spit up, they burp up, food comes up. But with this is this projectile vomiting. This is very forceful vomiting. So this stomach is now becoming over distended. It's getting very stretched out, and to alleviate pressure on that stomach, you're going to have violent contractions of that stomach, and it's going to force that food out very violently. So these are the kids, when they vomit, it goes flying. Like you could be standing like a foot away from this kid and you're going to get hit, So this is a very forceful vomiting that occurs with pyloric stenosis, and it's called projectile vomiting. So these babies, they're going to be a couple weeks old, usually about a month old. They'll come in with episodes of projectile vomiting after feedings. So the mother will feed, nothing's passing through, the stomach's getting it distended. They'll feed the kid again, kid's stomach's getting more distended, and then eventually they'll wind up with these episodes of projectile vomiting. The condition occurs from 1 to 5 weeks of age. More common in males. See it more in male babies. It's actually a 4-to-1 ratio, so 4 times more likely in males. So patient prep for this exam. So this exam could be a little bit challenging. It's up there with one of the more difficult ones that we do. But we're going to have the baby be MPO for 2 hours. So we want to try and give that stomach a chance to empty if it indeed is a normal study. If this baby does not have pyloric stenosis, we have the baby be MPO for 2 hours. So patient prep. Go for 2 hours. That's in order to give the stomach a chance to empty. So that'll provide us, a good baseline So if we've had this baby NPO for 2 hours and we get him up and we see a big, huge, full stomach full of, fluid or milk, we know that there could potentially be an issue. This patient should have a contracted stomach by the end of 2 hours. So we will have them NPO for 2 hours. We will then attempt to image pyloric channel. And the good thing with this exam, if it's positive, it's much more easier to see, like the appendix studies that we do. A positive pyloric study is it's definitely noticeable. Another thing that might help is turn patient right. To cube the baby a little bit, I'll roll up a little towel, put it under the baby's back, roll them towards you. So that'll actually help to kind of shift the pylorus channel or that pylorus muscle and the distal part of that stomach, the distal antrum, towards the liver, and allow you to use the liver as your sonographic window to try and image it. And also help with issues with gas. So then you'll attempt to image the pyloric channel. So this will be pre-feed. Pre-feed. And then the next portion of the exam is going to be post-feed. So we will give baby. In our lab, we used sterile water. Some places might use some Pedialyte. So we had these little bottles that had sterile water in it. And then I would put those little sweeties that I talked about that have that little bit of sugar flavor. I'd squeeze 1 or 2 of those in the sterile water because oftentimes the babies, they never had water before, typically, and they don't get used to the taste of water and they won't drink the bottle. So some places will use sterile water or Pedialyte. Want to make sure it's a clear fluid. If it's a last resort, then breast milk if you have to. But you want to try and feed the stomach at this, fill the stomach at this point. So we'll feed the baby the sterile water. It'll take a couple minutes, but it's a good opportunity. The baby will typically calm down at that point, relax a little bit, and let the mother hold the child, sit in a chair. You give them the little bottle of the sterile water, Pedialyte, so they'll feed. And instinctively, the mother is always going to be like, how much does they have to drink? The more they drink, the better their exam's going to be. So try and encourage them to try and drink as much as possible. So then you're going to fill the stomach, and now you're going to re-image. Pylorus channel. And you're going to want to try and get a cine clip. So capture clip of channel opening and fluid passing through. So if this was a negative study, If this baby was, you know, a normal baby that just, you know, happened to be vomiting and throwing up, and it was a nervous mother, you know, first time mom, like, oh my God, this kid's throwing up, what do I do? You know, they want to rule out pyloric stenosis. They're NPO, so that stomach should be contracted. There should be nothing in it if it's a normal study. We try and attempt to image the pyloric channel pre-feed. You may not necessarily see it because the stomach is contracted, so there's not that fluid within the stomach to act as an acoustic window. There may be a lot of gas, so we may not necessarily even see it pre-feed. You know, we'll try and turn the patient towards our right to cue them a little bit. That might help. And then we'll move to our post-feed imaging. At this point, we'll give the baby some sterile water, fill the stomach. And usually when we fill the stomach, we're able to visualize, you know, the pyloric channel at that point. And then we'll try and capture images in a cine clip, particularly that cine clip that's important, of that pyloric channel, that pylorus muscle opening and the water passing through or fluid passing through. So that is just how we prove that it is a negative study for pyloric stenosis. There are some measurements that go along with this study. So I'm gonna bring this in a little bit so we get a good view on it. So this would be an example of a hypertrophic pyloric stenosis. A normal pyloric muscle, you may not even necessarily appreciate. They're just going to be small little muscle on either side of your channel. So this will be closed and your little muscles will be right there. So in a normal study, there typically isn't much for you to measure. One of our pediatric radiologists said if it's a normal study, they don't even want measurements. Just get your clip showing a nice normal looking pyloric channel, opening, fluid going through. So in cases where there is a hypertrophic pyloric stenosis, so I drew these two layers. So there's a small space in between these two layers. That's your actual pyloric channel. This is the pyloric muscle, which is now hypertrophied and grown. And when we're measuring this, we're going to measure the length of the channel as well as the muscle thickness. So the way I remember my measurements is pi, 3.14. So our thickness positive pylorus thickness, it's going to be greater than 3 millimeters. And channel length is going to be greater than 1.4 centimeters. So your length for your calipers, measure across that channel length. And remember, as this muscle gets thickened, the weight of it is going to actually typically pull it down. So that's another thing too. A lot of oftentimes a positive pyloric stenosis, you're going to wind up with that pyloric muscle posterior to that distal antrum. So it's going to kind of bend down. So it's not going to be a straight line across. So it might be beneficial to do an open trace and try and trace it. Like if you're like, tracing the cervical length. I don't know if you guys do an open trace when you're measuring your cervical lengths, but it's kind of similar to that. So I find it easier to just do the open trace function to get a real true channel length measurement. And in terms of thickness, there's going to be a hyperechoic area. So the thin channel in between the two layers. There's going to be a hyperechoic. This is hyperechoic, this layer. Hyper. And then there's going to be a hypoechoic layer immediately preceding that. And then an additional hyperechoic layer on the other side. So the way I was always taught was that to measure just the hyperechoic layer in that segment. I apologize. I did this kind of backwards. So this is I'm sorry. Hypoechoic. So measure the thick hypoechoic layer in between. So some radiologists, so we're going to measure the hypoechoic muscle thickness of that layer, that thick hypoechoic layer. So again, our most accurate measurements, you could take one in your long view, but it's important to also try and get a transverse view of that pyloric channel. So our transverse measurement is going to be our more accurate measurement. Again, you're going to try and measure the hypoechoic area. I think what else. So for hypertrophic pyloric stenosis, so my transducer orientation. So I'm typically going to be kind of like in an oblique scanning plane. So I'm trying to just kind of visualizing that pylorus muscle coming off here. So I'm kind of like in a transverse oblique plane, trying to get a long image of the pyloric channel. And these studies, you know, they can be quite challenging if the baby's been crying a lot and they have a lot of gas. But again, a positive pyloric study will definitely be much more noticeable than a negative study, and they're a lot easier than a negative study. So intervention for this is surgery. They do take the babies to surgery to reduce this muscle. They essentially just shave it down. It's actually a pretty minor surgery, and the babies are discharged fairly quickly. So they shave that muscle down, open up the channel, and the baby's good. So outcomes are good. So again, you can go online, you know, review some of the images of what these exams look like. Now it's for you to review. If you have any questions, you guys can always email me. I'll try and answer back as soon as I can. And enjoy your weekend. Thank you.